really wonderful speakers, very well-known European panelists. We have really very hard questions to them. Very important discussions will happen. We know that cervical cancer is very important in our region, and I hope tonight we will have answers to many, many questions. Thanks to Dilyara, the president of Sentis and also Kazakh Oncology Institute, and who is, supporting this webinar. Thanks to all of our speakers, panelists, and regional scientist experts tonight. We believe we will be together around 2 or 3 hours. And I want to start very immediately, but before starting, I want to inform you that we have simultaneous Russian translation. What you need to do is just select a channel in Russian in the below box. So the ones who wants to show and watch the webinar in English, please move in this channel. But the others should move to the Russian channel. And on the other hand, according to the latest news, we have around more than 3 participants currently watching us only. It is really a very, very huge number. Congratulations. We have many participants from Kazakhstan, Uzbekistan, Turkmenistan, Georgia, Ukraine, Russia, Turkey, Iran, and many other countries in the region. Thanks to all of our participants. Now, let's move first to listen who are the speakers tonight. I want to first introduce Christina and then Dimitri, and then we can move to the speakers. Christina, let's introduce.
Very nice to see you all. A pleasure to see you all. Thank you for making the time. And I hope the next webinar series can be face-to-face. It's a pleasure to have you all.
Thank you so much, Christina. Dimitri from Greece.
Yes, I would like to welcome all the speakers, very distinguished speakers, and I hope this is going to be a sequel, the Scientist Hard Talks. It's been very successful, and I think it's going to be more. So I would like to thank all the speakers for being with us, and I think it's going to be a very good webinar. Thank you.
Thank you so much, Dimitri. Now I want to give the microphone to the panelists first. You already know the ESGO president, Philip Morris, is with us. We are so grateful to all of his supports. Philip, we are with you.
Very happy to be with you tonight with this scientist meeting. So it's a great pleasure and honor for me to be there and to represent the ESGO.
Thank you so much, Philip. It's a special attention I want to give. The people have so much interest on ESGO, and with your presidency, ESGO is doing a lot of activities in the scientist geography. We are so happy what you are doing with us. You are listening us and trying to find solution for us. Thank you so much. Now, the next panelist, we are going from Paris to Germany. Christa Köhler.
Hello. It's a great pleasure, and I really thank the organizing committee and the colleagues from Kazakhstan to invite me. It's a great pleasure to talk with you, especially all the controversies. It's going to be a great meeting. Thanks so much.
Thank you so much, Christa. It's so great pleasure for us to be with you tonight. Now, from Germany, these 2 countries are out of the European Soccer Cup, you know. We are going to another country, Greece. Alex. Who are
very nice. It is very nice to be here. I would like to congratulate, and I would like to thank you very much for the invitation to participate in that scientist webinar on hot topics for cervical carcinoma. It's very nice to be here and with you.
Thank you so much, Alex. Now we are moving to the winners of the European Cup slowly. Now, one of the favorite soccer teams from Netherlands. We are going to Remy now.
Ouch, you touched a hard spot there also for hard talks. Unfortunately, we are not in anymore. But thank you very much. I would like to thank the organizing committee for this opportunity, and I'm really honored also to be present with this team and with this nice discussion. Thank you.
Thank you so much, Remy. The most favorite country, of course, is Italy. They are doing good job. Our favorite. Giovanni, are you watching the match or are you with us? We want to see your face. Hello, Dobrica, Roma di Milano, and you are listening to now Giovanni. I will call him. Giovanni is probably watching the match now. Now let's move to Ukraine. Vlad. Vlad, you can talk. You are muted. You are muted.
Oh, sorry. Dear colleagues, nice to meet. It's very pleasant to be invited to participate in such an interesting webinar concerning cervical cancer, which is a hot topic in not only in Europe, but in the world. Nice to see everybody in good mood.
Thank you so much, dearest Vlad. And Italy is coming. We are at the penalties. Yes. Giovanni, once again, we are with you.
Thank you very much. It's a pleasure for me to be
here. Andre, okay. Thank you so much, Giovanni. It's a great pleasure for us to have you on board tonight. Now, let's go to the Sentis countries. First, from Turkey, we have Professor Faruk Köse. Welcome, Professor.
Thank you very much, Murat. First of all, I want to thank the kind invitation of the organizing committee. It's a pleasure for me to be a part of this webinar.
Thank you so much. Tonight, from our region, we have also Georgia, in addition to Ukraine. Dina.
Hello. I would welcome to all participants, moderators, and organizing committee. It's great pleasure for me to be here in this webinar and looking forward for hard talk.
Thank you so much, dear Dina. We have really hard questions coming still from the participants. The numbers again are, as I see, is increasing. And my final words to Dilyara. Dilyara is the president of Sentis, the president of Kazakh Oncology Institute. She is supporting all these events on behalf of Sentis, the hosting country of tonight's webinar. Dilyara, I want you to introduce yourself. And the people wonder, what is Sentis? Can you just show a few slides about Sentis and inform the people what we are doing?
Hello, dear colleagues. Welcome to webinar Hard Talk on Cervical Carcinoma. We are very grateful to our great panelists for the sparing your time to be with us. Many thanks to Murat, Christina, and Dimitros for the organization. Few words about our East group. In 2018, we have created the East trial groups, new research network, which include 40 members from 10 countries. Research network was founded to provide active support to gynecological researchers and advancement in prevention, diagnostics, and treatment of patients with gynecologic cancer. Eastern Europe and Central Asia region includes 18 countries with population about 400 million people, and it is one of the regions with a high incidence and mortality from cervical cancer. And how we work. As you know, young scientists often do not have data. Usually all data is retrospective and don't have a network. But senior researchers have a good clinical practice, patient database, network, and don't have time. And scientists decided to make a bridge between young and seniors for developing regional clinical trials. And what is the structure? Research proposal come from different centers of the Centeast. Principal investigator apply call for projects from the operational center. Then young brainstorms usually have more time to prepare the protocols, making database and follow up. In addition, young brainstorms prepare draft of a manuscript according to authorship rules and collect data. Country representatives evaluate the project applications, discuss and decide on the final protocol. And what we done? Starting from February 2018, Centeast was invited by Gynecological Cancer Intergroup. Centeast has cooperation with CGOG. Initially, we published the rules of authorship in the International Journal of Gynecologic Cancer. And you can see our first protocol, Saturn 3, an international multi-center study. The study includes data from all Centeast countries. The study was in collaborations with CGOG and was published in the International Journal of Gynecologic Cancer in September 2019. Let me thank to Dr. Kahramanoglu for your initiative in this study. And our team started a new project, OPEC, ovarian preservation in endometrial cancers. Principal investigator, Dr. Agor from Turkey. Here are the preliminary results of the study. More than 10 countries participated in that study. About 160 cases were analyzed. And during these 2 years of collaborations, we have done a lot of work on the study of gynecological cancer. Centeast is a time of like-minded people, and we have enough strength to continue our fruitful work. Thank you, and we are always open to collaboration.
Thank you so much, Dilyara. It was wonderful slides. I am also so proud what we are doing all together. Dear friends from European experts, I mean, it was not traditional in our region to come together and to make something, even if it is retrospective, to make some publications. And we are so happy. We are so happy. Many countries like Georgia, Russia, Azerbaijan, Armenia, Turkey, Kazakhstan, we can come together, Greece, Ukraine, Belarus. So we know that we have some historical background. We know that we have some relations with UNESCO, and we are so proud to do some publications and open to any of your ideas, any of your investigations or research. So, dear friends, tonight our topic is hot. The hot talk is in a hot topic, the cervical cancer. Maybe just before starting, I can ask to Christina just to talk about a few words as a welcome to cervical cancer. What is the debate? What we should ask? What can you give an overview? What's going on in cervical carcinoma, Christina, as one of the leading European experts?
Thank you very much, Murat. Thank you. Again, a pleasure and honor to be in this panel. So, and cervical cancer is a disease that has changed massively over the last decades. And this is down to many people that are actually on this panel today of your work, Murat and Rami and Andre, everybody on this panel. We have had a massive change in management with the HPV vaccination, with screening, with introduction of HPV screening instead of the regular smear test, and of course with a LAC study and with a SHAPE study. It is a disease where I remember when 20 years ago when we started, or when I started gynecology, I remember the definition of a gynecology, radical gynecology surgeon was the wartime surgeon, yeah, the radical hysterectomy surgeon. Exactly. And this has gone completely away from that. Yeah, we are now talking about minimal invasive, not even radical hysterectomies in smaller cancers and irradiating larger cancers. So the whole philosophy of how to treat this disease has changed. We are moving much more towards fertility sparing. So studies are now happening in order to show that there is actually equally effective or equally oncologically safe to be less radical than more radical in terms of a cone excision instead of trachelectomy, instead of simple hysterectomy instead of a radical hysterectomy. So all these are questions that are going to face us in the next decades, and they will change the face of the management of the disease even more. So we have prepared a list of questions for you experts today, where we're going to discuss these issues. And I hope it will be a very interesting discussion.
Yeah, thank you, Christina. But I understand that in contrast to ovarian cancer, we are moving to a less radical treatment in cervical carcinoma. But this change in our treatment approaches produces many questions in our minds, because we give our life to learn radical hysterectomy, and now the people is saying that it will not be much more used day by day. Less radicality is coming. So I believe we have lots of questions on this respect, and I want to give the opportunity for the first question to you, Christina. Let's give the first question to whom?
To the president. The first question goes to the president. So, and Philip, this is something that we have discussed a lot in the past. What are, in summary, the changes of the FIGO classification of cervical cancer, and what do you think are the main implications on practice from that change in the staging?
You are now muted.
Philip?
First of all, I would like to thank Kiliana and all the organizers to be with you. It's very an honor to be with you. And I prepare a couple of slides just to go ahead with this discussion. I don't know if you can see them, but you can see here the summarize of the main modifications. Could you see it?
Yes, we are starting now to share the screen. Yeah. Mm-hmm.
It's very brief, because I know that we have only 5 minutes for each talks, but you can see here the modification that we had in the new FIGO classification and the last one. And just to tell you that you can see during the last months, we have also a new TNM classification that have been revised a few weeks ago. So previously we have only clinical past evaluation for the staging, and now we have a clinical, radiological, and pathological if patients go to the surgery. The stage 1A is defined only on microscopic diagnosis, on cone biopsy or hysterectomy, and this required 3 margins. I summarize here all the main modifications of this FIGO classification. Concerning the stage 1B, for example, you have a stage 1B1 less to 2 centimeters, 1B2 between 2 and 4, and 1B3 about 4 centimeters. For stage 1A, very important issue, the surface of the involvement disappeared to define its disease. For stage 2A, the size of the vagina involved, it's 2/3 of the vagina, upper 2/3 compared to 1/3 previously. And for the nodal involvement, we have a new stage 3C disease, the 3C1 and 3C2. It's not very original to show it to you, because you know this different data. The new TNM classification changed one point that is interesting, is related to the nodal involvement. And you can see here that the new TNM classification defines micrometastasis with a very small spot of involvement in the lymph nodes between 0.2 millimeters and 2 millimeters. And you can also define a specific group of patients in which the sentinel node is diagnosed with an SN before the nodal specification. What is lacking for me from my side in terms of clinics? The first one, and I don't understand why, I know why, but I don't understand why in the endometrial and cervical cancer, the lymphovascular space involvement status is lacking. The response is very clear. It's lacking because it's very difficult to define them. There is no reproducibility between the pathological community to define them. And also the cutoff in terms of prognostic value of the number of lymphovascular space involvement is also a hot issue. But for me, it's not logical to do not add them at least in the cervical cancer and also in the endometrial cancer. The cutoff of 2 centimeters is also a cutoff that could be discussed, because in the literature there are very few data to support a cutoff between 2 and upper 2 centimeters, except for the question of fertility sparing management, and we will see it with the next point of with Alex that will cover it. But from my side, it's more logical to appoint probably a new group of patients with a upper size probably closer to 3 centimeters. And you remember well these excellent trials of Fabio Landoni, who was updated 2 or 3 years ago. It was one of the major trials about cervical cancer comparing radical surgery and radiation therapy, and analyzing 20 years of follow-up after this trial. Fabio found a cutoff around 3 or 3.5 centimeters. So this is an important issue to define the targets between patients that are relevant for initial surgery or radiation therapy. And at least the question also of very specific analysis of patients with adenocarcinoma is really crucial. And we cannot cover it on the same way that we cover squamous cell carcinoma. And I just referred to you to this very excellent paper that had been published a few weeks ago with the pathologic community, which is really excellent if you want to cover all the specific comments from the pathologic community to classify a patient with adenocarcinoma in a different way than patient with squamous cell carcinoma. So I need to stop it. The few points that I want to stress about the staging and the debates about staging and the new FIGO and TNN classification.
Excellent. That is excellent. That is excellent, Philippe. I fully agree with you with the LVSI. This is something that we always discuss. The LVSI is determining practically whether we will irradiate or not. Yeah, very often in cervical cancer. I mean, I remember, I will never forget, I was in an MDT in Australia, yeah, with, and it was a small tumor, 2 centimeters, and because of extensive LVSI, they didn't want to operate. They said, oh, we'll just keep tumor out, which was very, you know?
Yeah, for sure. Yeah. Yeah.
You know, so it is, and it's something that has not been acknowledged. I hope it will be in the next. From the panelists, there is a question from Murat. How about the heterogeneity of lymph node positive cases? Should they all be classified as stage 3? Prognosis depends so very much on tumor size. What are your views?
That's a very good question, as usual, Murat, because we should be aware on one fact, and this has been also raised in the paper that I showed you about the adenocarcinoma and the comments from the pathological community. We should be aware because most of these cases are observed in low or middle income countries, where we can also have some patients with infectious disease and particularly tuberculosis that can have nodal spread. So if you move on, and it's logical to have only imaging to screen patients with nodal involvement, we should be very aware of the screening between what is related to the cervical cancer itself and what could be related to the chronic infection disease to specify really what should go to the chemo rates, for example, or to be explored with a puncture or something else. And to reply to your question, probably I remember perfectly well, if you remember Gillian Thomas. Gillian Thomas was a very great lady, radiation oncologist. We were working in Canada. She was very strong. And I perfectly remember 1 decade ago, we have debates together. And probably when you look at the previous results of the Peters trials, you remember the Peters trials where the to go ahead with the chemoradiation in patients with nodal involvement. It was published in 1999, and there was a cutoff in terms of prognosis between patients with a single node involvement and patients with several nodes. So probably the question of the management of patients with an isolated single node is probably different than patients with several nodes that need to go to chemoradiation.
Exactly. Like the vulva, no? In vulva, we also say it's 1 node, how extracapsular involvement, how many nodes, etc. Excellent. Yeah. I think so that we don't go too much over time. I give the talk now to Dimitris, and thank you very much, Philippe, to Dimitris and Remy. Dimitri.
Okay, hello. So Remy, the next question for you is, what is the role of MRI and PET-CT, or combination of those, for staging? We're coming back to staging again, and what is your opinion about that?
Thank you, Dimitri. I think, first of all, just some remarks, because I think that the importance of the role of imaging has now become really clear, also by adopting it in the FIGO classification, staging classification, and giving it really a role in assessing the stage. So furthermore, I think there are several important factors that need to be taken into account, and it is, of course, the availability of certain types of imaging in the given setting, because we can recommend all kinds of imaging modalities, but if they do not, certain modalities are not available, then we have to adapt accordingly. I think these are two really important factors to take into account. And another one is also the consequences of management, let's say, in the team, because there still are some adaptations that you can make based on the overall management decisions in the team. So to summarize on the role of imaging, I think with regard to local imaging, MRI has the most soft tissue discriminating abilities. Also, ultrasound in expert hands is recognized, and there are multiple studies also comparing over experienced centers that it has an important value in the assessment of the local tumor extension. But with ultrasound, of course, you are limited with regard to the nodal status. That is an advantage of MRI, that you have both local imaging and nodal imaging. And when you move further away from regional towards distant, then you come to the role of CT. Normal CT, contrast enhanced chest, abdomen, pelvis, has, of course, both the abilities to assess lymph node spread as well as distant metastasis. And then you gradually arrive at the role of PET-CT. And PET-CT, of course, has also important additional value, because it also can inform us about enlarged lymph nodes, and it can also inform us about unexpected distant metastasis that comes out of each study with PET-CT, that there are unexpected findings in around 5% of cases, which are also often have important management decisions. And in cervical cancer, for example, also simultaneously, for instance, lung cancer is something that we occasionally can observe. So in summary, for the local MRI or ultrasound in experienced hand, for the regional MRI, but also CT, for regional and distant CT and PET-CT.
Thank you very much. It was very clear. I have a question. What do you think about, there are those that say that there are limitations of the PET scan following radiotherapy for cervical cancer and before brachytherapy, that PET-CT scan has limitations after radiotherapy. Would you say that, I mean, will there be a role of MR PET for, in these cases, to see better the parametrians?
So maybe just to clarify, did I understand correctly, between external beam radiotherapy and brachytherapy?
Yes, because there seems to be a limitation of the PET after radiotherapy.
Yeah, so I think the most important reason to have imaging at the time of brachytherapy is to have a correct anatomical delineation of the remaining residual tumor at time of brachytherapy. And MRI gives the best let's say, clearest anatomical visualization of the remaining residual tumor volume. Yeah, so I think there the answer is MRI. Ultrasound together with CT can also, is now also being proposed, and I think that we will soon see more studies with clinical data using the combination of ultrasound at brachytherapy and CT together combined. And I understand the hesitance with PET-CT, but I think this is also related to what you have available, I think.
But there's a question actually from the panel that what should be maximal days to wait for MRI? In some countries, it can take 2 months to have an MRI. That's a major problem, especially in the Eastern countries. There might be a lot of delays in that area. So you believe that ultrasound would be an alternative for that?
I think that's an excellent point, because we have very good data that both delaying treatment as well as prolonging treatment, so not keeping to a short overall treatment time, negatively impacts on the outcome, the prognosis and survival. So I think it should be prioritized that this is also important factor to take into account when deciding in a given patient what is the optimal imaging modality. If you can have a good CT in a week's time, then in certain cases, I think that is the best decision compared to waiting 2 months for an MRI.
Okay, so that's a very good answer. Murat, do we have time for another question? There's another question in the panel. Do we have time for that? Where is your suggestion for LMIC where PET scan is limited?
Yeah. I mean, can we treat cervical cancer without a PET-CT?
Yes. Yes.
No need for PET-CT. It's not an absolute thing for treatment and follow-up. Huh?
No, then if PET-CT is not available, I would go for CT chest, abdomen, pelvis, preferably, or even a CT pelvis, abdomen, and leave out the chest. If you even have to, condense further, to at least be informed about the regional nodal status. And then you can be also more selective with further imaging.
Thank you.
Okay. So we'll move on to the next question by Murat.
The next question is coming from me to Italy, to Giovanni. Giovanni, it's a hard question, really, and you have 5 minutes to answer. And I think we can discuss more on that. The question: how about staging of para-aortic lymph nodes prior the decision of chemoradiotherapy? Do you suggest or use PET-CT, or do you suggest or use surgical removal of the para-aortic lymph nodes? How to make a decision?
Okay, thank you, Murat, for the invitation, for the question. I think that it's not easy to answer to this question, and I will try to do my best, just using some slides. Do you see the screen? Or?
Yes,
yeah, very well.
Okay. Okay. So I think that this is a very hot topic in gynecologic oncology, and the information about para-aortic metastasis is important since it impacts the prognosis of patients, but also it's useful to tailor the radiotherapy with extended field radiotherapy. So it's a very important question. And we also, if we look to the ESTRO-ESCO-ESP guidelines, you see that in the last version, they recommended that para-aortic lymph node dissection could be done, and this can be done to the inferior, at least to the inferior mesenteric artery, and this procedure can be considered before chemoradiotherapy and brachytherapy. I think that the discussion and the question arises from from this data, which are resumed in this slide, in particular, we know that imaging techniques like CAT scan and MRI carry a false negative rate of 20-23%, while PET-CT scan was shown to have 12% of false negative results based on several review articles. And on the other hand, the surgical staging in expert hands is able to provide histologic information with very low risk of conversions to laparotomy and very low risk of severe complications. One of the largest retrospective study is shown in this slide and was published 3 years ago and showed that lymph node surgical staging had an independent positive impact on survival in patients with locally advanced disease. And this data was confirmed also in the multivariate analysis. However, we lack at present, we have only 2 randomized trials because two other trials have been prematurely closed due to the lack of accrual. In the first study, which was published by Lai and colleagues, the benefit of pretreatment surgical staging for cervical carcinoma remain unproven. Nevertheless, the present trial suffers from limitations such as small number of patients, high rate of severe toxicity, and premature closure of the trial. Very recently, the Uterus 11 trial was completed. This was a very clear prospective randomized trial, randomizing locally advanced patients to undergo surgical versus clinical staging with CT scan and extended field radiation according to para-aortic lymph nodal status. This trial concluded that no difference in disease-free survival between surgical and clinical staging in patients with locally advanced cervical cancer. There was only significant benefit in disease-free survival for patients with stage 2B, and however, the major limitation of the present study, in my vision, were related to the use of CT scan instead of PET-CT scan, and to the final population included in the intention to treat analysis, which was lower than the planned population. So just to answer to your question, I think that metastatic para-aortic lymph node in locally advanced cervical cancer carries a significant prognostic impact. Information about para-aortic node positivity is important to tailor radiotherapy and extend the field to the para-aortic area. However, there is still controversy in terms of survival benefit of performing para-aortic node dissection. Probably the only potential benefit at present would be in selected patients, such as FIGO stage 2B. And the question is, do we need to change in the future, the current guidelines? Thank you for the attention.
Thank you so much. Thank you so much, Giovanni. I think it is the best summary of the world up to now in such a hot topic. Just before going to further discussion, there is a very small echo in the live stream YouTube channel, especially in the Russian channel. I want to ask you if there is an open cell phone or something that may be better to stop it. Okay, Giovanni, this topic is really very hard. There is first of all one question. Usually in the guidelines, the people recommend minimal invasive extraperitoneal lymphadenectomy, but this is not so valid for many countries. I mean, it needs experience. The question from the scientist people is that, can we still continue on open surgery for lymphadenectomy before radiotherapy?
So I should say that in the absence of clinical data suggesting for a real benefit, I think at present it is not justified to do surgery only to assess the lymphnodal status. If you can do this by minimal invasive surgery, we can discuss, but to open an abdomen just to get such an information, in my vision, is not justified at the moment.
Thank you so much, Giovanni. I want to ask to ESGO and our president and our panelists. So currently, what is your suggestion for the surgical staging? Should any comment from the panelists on that? In our country, we usually do PET-CT, and according to the results of the PET-CT, we decide on surgical staging. How about the others?
Yes.
I agree with the comments from Giovanni. Just to say that we modified 2 years ago our strategy in Gustavo Sier, and we just continue to use the parotid lymph node staging surgery by laparoscopic approach in patients with positive PET-CT imaging in pelvic nodes, because we know that in this group of patients we have 24% of patients with parotid node that are not diagnosed by the PET-CT. But in the group of patients without any effects in the pelvic node, we stop using parotid staging in this group of patients if we have initial PET-CT imaging.
So the only thing that I can say is that we are now in the process, David Chibula is in the process of updating the cervical cancer guidelines. So there will be an update, which I hope will be out next year. So we will definitely take into account the data that Giovanni showed, including the lack of survival of the Marnitz and Köhler study.
So, dear friends, I will give the next question actually to Christina, but we know that Rami will make another presentation in an ESGO meeting, and he has the last 15 minutes with us. So maybe it is better we have some questions specifically to radiotherapy. Christina, maybe we can move to question 7 for Remy, and then question 8, because he can leave us. Can you see our question, Christina?
Yes. So Remy, stage 1B3, 1B3, yeah. So the 1B3 is now the larger tumors. Would you suggest chemotherapy? Would you suggest surgery? Would you suggest chemorads? What would you suggest? The above 4 centimeters tumor. How would you do the therapeutic algorithm of the?
Yes, thank you, Christina. I think this is over the years one of the most debated tumor stages. I think we have. I think this also is very much dependent on the integrated approach, multidisciplinary management approach that a center adopts, and especially regarding to the value that is attributed to risk factors. Because in a way it is quite logical that the larger the tumor gets, the higher the chance of risk factors being present in a given patient. With risk factors, there are two types of risk factors. The first one is the risk factors. I think that we have overall consensus for the role of radiotherapy, and that is lymph node positivity, parameteral involvement, and positive tumor margins. There, I think that there is overall a high agreement for indication of adjuvant treatment. When it comes towards what we call intermediate risk factors, and that is different combinations of the presence of lymphovascular space invasion, depth of tumor invasion, and the tumor size, then we come into an area of more debate and also different data. And of course, we are all well aware of the SETLIST trial, but this trial has also had different comments, and it's already also performed in I would say a different era with different, for instance, imaging available, etc., etc. So I think it's good that this is also debated, but we also cannot we cannot leave this trial out of the overall assessment. So these are the considerations I think that are very important. And in our practice in 1B3, for us, it is a situation where we estimate the chance of risk factors being present as very high, and we want to prefer to avoid this combined, the higher chance of morbidity from the combined modality approach. But again, this is more an area of debate, and there are also examples of surgery preferred with also good outcomes presented in literature.
Exactly. So there is a question from the audience saying that David Chibula, who is leading the cervical cancer guidelines, there is a talk which he is giving, and there is where he says that in 1B3 tumors, there is actually no level 1 evidence to say that radiotherapy or surgery is one better than the other, and that surgery might as well be good enough. What are your views in that, in terms of in view of the new imaging that we have, that we can see now lymph nodes and metastases that we never used to see before? You know, in the past we were just operating with a simple ultrasound or an MRI, and now we have PET CTs. We see microscopically involved nodes that we wouldn't see before. Pathology is better. So what would you answer to that?
Well, I think that we still cannot see microscopic disease in lymph nodes. So I think there really is a value in patients that are node negative on imaging. The best information on lymph node status comes from the pathological evaluation.
Exactly.
Yeah. Mm-hmm. So I think that's clear. I think that's clear about the role of evaluating the lymph nodes. That's what I mean.
Yeah. No, it's fine. Murat, thank you very much, Remy, as always, brilliant. Murat, would you like to continue with Remy? Shall we? Yeah. How would you like to do that?
I think there is another question prepared to Remy before he departs. Dimitri, can you forward this question?
Remy, there's another question for you. Sorry to bombard you with questions. So this is a very interesting question. It's about if there are any cases that we would only do brachytherapy and not external beam radiotherapy and brachytherapy. This is a very interesting question. What is your views about that?
Yeah, so that's indeed an interesting question. I can come up with one situation, and that is actually a situation that Philippe Maurice is more aware of than I am myself, because this is very much the French school where in patients within, let's say, the range of the 1B3 group that we discussed, receive pre-operative brachytherapy, and that is often associated with a very good response because it is radiosensitive, and quite a high rate also of complete or at least near complete remission. But Philippe, I think, can also talk about that. And by doing that, you also, in the majority of cases, avoid the need for postoperative pelvic external beam radiotherapy. So that is I would say, the French school in that management of that group of patients. But otherwise, there is no strong data for brachytherapy alone. That would be my proposition. Maybe one other situation, that is in the situation of recurrent disease. We have more and more data of the use of brachytherapy also in the re-irradiation of locally recurrent central pelvic disease. So that is another situation, but that's more rare and also specialized.
Okay, thank you very much. Actually, the second, I have two questions. The second one was just answered now by the brachytherapy in cases of recurrent disease. But I wanted to ask you, would you consider brachytherapy only in small volume disease for patients that are not candidates for being operated? Patients that are not, cannot go to surgery, could we do only brachytherapy with small volume disease? Would you consider that?
As far as we do not have very good data to support this, I mean, in terms of evidence-based. But I can think along, and there are parallels. If you are managing disease that surgically, you are 100% risk that that nodal spread is not a problem. Then theoretically you can treat only locally, and that's in very small disease, and often you will have a very high chance of cure in this situation. But this is, for me, I think this is more hypothetical, and that we have good data from my point of view.
There's a question from the audience also, that the radiation companies favor external radiation a lot. Is it true that what do we need brachytherapy with new technologies? This is a question coming from a radiation oncologist. So actually, I think that what he wants to ask is can we switch it around, do only external beam and not brachytherapy?
Well, I think that I can be clear about that. We have good or relatively good data from large studies that brachytherapy is associated with a survival benefit compared to external beam alone. Also replacing, let's say, trying to replace brachytherapy with modern stereotactic or surgical approaches with external beam radiotherapy. So it is something that is investigated also with modern equipment such as integrated MRI LINAC machine or other high technical machines. But still, with external beam, you will always treat more of the sensitive normal tissue around the tumor, and the dose that you need to control the disease will give more side effects than brachytherapy. That is the equation at the moment. So that is why we still propose combined external beam and brachytherapy.
Okay, so the question is answered. We should combine external beam and brachytherapy. So thank you very much for all of these questions that you answered. And I believe that Dr. Remy now can be dismissed to attend his other.
Remy,
well, thank you very much.
Thank you, Remy, for being with us. Thank you. We know how busy you are.
Actually, before leaving, Remy, maybe it will be nice to have a joint picture of tonight's all the speakers together. Dilyara, can Raihan from your office have a picture all together? Yes.
Oh, 1 second, we will do.
Okay.
One, two, three, please.
And you know, this is the Zoom picture now, something like that. What I learned from Janet. Let's do two hands together, yeah. Okay, one picture. Yes. Thank you so much, Remy. It was so nice. If you have time, if you have a little bit time, you can join the next question, the set this criteria. But I know you want to escape from this discussion. So you can feel free on that. Thank you so much, my dear friend. Again, it was so nice to have you tonight. So let's move to the next question where we
Let's take the sequence. The sequence it's to Alexandros Rodolakis about fertility sparing surgery.
Yeah.
Excellent. So thank you so much for being here. We have a question. How would you identify the ideal candidates for fertility sparing surgery with cervical cancer? How would you tailor your patients? How would you identify them? What do you think is oncologically safe to do?
Thank you very much. Thank you very much, Christina. Thank you very much. And conization and radical trachelectomy are considered, with or without lymphadenectomy, are considered the fertility-sparing treatments for cervical carcinoma, especially for stages 1A to 1B1, according to the low relapse rate, and of course, the excellent results for women to achieve pregnancy. For patients with stage 1A, conization seems to be suitable with low abortion rate and preterm delivery rate, and of course, an excellent oncological outcome. Lymphadenectomy in stage 1A2 in either the systematic pelvic form or in the sentinel node dissection in cases in experienced centers is recommended. The radical trachelectomy has been now recognized as the alternative and the fertility-sparing approach for young women with less than 2 centimeters tumors, and that has been confirmed with excellent data, and in both vaginal or abdominal approach for cases with tumors less than 2 centimeters. The abdominal approach is suitable even for bigger and applied for bigger tumors up to 4 centimeters with the more radical excision of the parametria, but which is not well done by the vaginal route. But of course, it has been shown that it adversely affects the rate of pregnancy and live birth. And it has been confirmed that more infertility treatments are frequently required following that procedure, with premature rupture of membranes and premature labor frequently observed. There is an ongoing tendency during the last years about the need of, regarding the need of parametrectomy in small volume tumors for stage 1A2 and small 1B1 tumors. And there is a tendency less radical surgery for lesions less than 2 centimeters. And that has been applied also for patients, of course, wishing to preserve their fertility, suggesting that the parametrectomy may not be required in selected cases with small tumors, and instead a simple trachelectomy or even conization could replace the radical trachelectomy. For patients with more than 2 centimeters of tumors, of course, we know that there is a high recurrence rate for those than smaller tumor, less than 2 centimeters, and especially if LDSI is positive. Thus, obviously, the question for fertility preservation for those patients with more than 2 centimeters tumor is questionable. And to date, there is no optimal management of women with lesions more than 2 centimeters wishing to preserve their fertility has not been defined and established. There are 2 options. The first option is the upfront radical trachelectomy procedure, which is technically feasible, but there is a high proportion of patients require adjuvant therapy based on high-risk features like positive nodes or positive parametric involvement or intermediate risk factors.
You are muted, Alex.
The other option is that the neoadjuvant chemotherapy based on the results that we do have from the neoadjuvant chemotherapy for cervical cancer. And there are data that we have 5 studies from with the use of neoadjuvant chemotherapy followed by fertility sparing surgery and giving a 70% response rate. and a better obstetrical outcome because of the minimizing of the procedure after that in terms of conization and cervicectomy instead of radical approach. However, we should know that patients with suboptimal chemotherapy response have a high risk of recurrence and death. And of course, even the fact that neoadjuvant chemotherapy can potentially convert positive node to nodes negative, positive lymph nodes has been proven as a marker of more advanced disease, and these patients should not be appropriate for fertility sparing surgery. The patients, those, have to be first addressed, have to be assessed for lymph node evaluation, and these patients with positive lymph nodes should be excluded from fertility preservation. In these cases, in cases where neoadjuvant chemotherapy offers a complete or partial response in terms of less than 2 centimeters of tumor, the application of conization or trachelectomy or simple trachelectomy is an option for fertility preservation.
Excellent. That was very, very clear. Thank you very much. There is a question about preoperative brachytherapy. What are your views on that? I don't think I've ever seen this happening, to be honest.
No, it's not.
Exactly. So I don't think this is a common practice.
Has
Exactly.
a detrimental effect on both gonads and, of course, the uterus.
Exactly, exactly. And then the other question is an expected question. We know all this big trial now with unknown safety or less oncologic safety of laparoscopic versus open radical hysterectomy. What are your views of laparoscopic versus open radical trachelectomy?
Based on the,
do you have any?
Based on the data from the LAC study and from other studies, that has been shown that the prognosis of patients managed by laparoscopic approach is worse with a higher relapse rate and, of course, the high possibility of death from the disease. The laparoscopic approach is not an option right now in most centers for the management of for performing a radical trachelectomy.
Okay, so you would extrapolate the data also from the radical hysterectomy to radical trachelectomy. Okay, very good, excellent. Thank you very much. Any comments from the panelists?
Christina, please allow me now. I have to say one word. Despite the LAC trial, we just submitted our data for more than 500 trachelectomies, all done by a radical vaginal approach, and we don't have any higher recurrence rate. So I don't agree with the statement that we have to do all the cases by open approach.
There will be some data coming out. We also have now Pedro Ramirez and René Parella are now doing a multi-center analysis that show exactly the same, like you have said, Chris, that I think it will be very difficult to do a prospective randomized trial in trachelectomy. Very difficult. So
possible, yes.
It's a discussion that we need to do with the patients, but I think the retrospective data show that there is probably no difference. But as Alexandros said, the patients need to know the data, and it's at the end their decision. Excellent. Murat, I give the word to you.
Yeah, just before going to the next question, maybe Dimitri will ask that. I want to ask Alex, actually, thanks to him. We work with Alex and the ESGO Council, and he was the president of the Fertility Saving Task Force. Do you still continue with Frederick Amand, your collecting data, Alex, on this? It was a wonderful job.
Yes.
You did a pan-European data. I just wonder, what is the latest situation in this data bank? Are you still continuing? Should scientist people can send still data to you?
No, we don't. We don't collect from Europe from the Europe data. It's no, it's not. We don't collect pan-European data for that.
Okay, so the next question will come from Dimitri. Yes, Dimitri, we are with you.
Dr. Köhler, it's a pleasure to have you with us. And the next question is provocative. You know that we are now in the post-LAC era, and a lot of people is against laparoscopy. You're not against laparoscopy for cervical cancer. So what do you think is the role of laparoscopy nowadays in cervical cancer? Should we use it for tumors less than 2 centimeters? Should we not use it at all? Should we use it for more than 2 centimeters? What is your view?
Thank you again for invitation. And I would like to share my screen, if it's possible, to do that, to show a presentation. I'm prepared a little bit this. Can you see the full screen? Hello?
Yes,
yes, we can see it, yes.
Okay. I will hurry a little bit through the slides, but hope can give you a little impression about our opinion. Okay, you all know the data from the leg trial. I don't have to repeat this. I want to show you a short video, but it's not running. That's perfect. Then we have to skip it. The video showed exactly the problem of the radical hysterectomy done by the German state-of-the-art meeting, where they did a radical surgery with a manipulator, opened in a stage 1 B2 cancer, the cancer visible to the abdominal cavity, and spread the tumor and grasped it with sharp instruments. I tried to open it again. Can you see the screen now? Can you see the screen, please?
Yes, we see.
Okay.
10 slides together.
Version. You see, this was told to us that this was a state-of-the-art meeting.
But Christoph, can you make full screen? We see all slides together now.
Full screen.
Is this a full screen?
No.
But can you see
put it in a full screen?
We can see your screen, but it is not full screen one slide. We see 10 slides, 12 slides, something.
Okay. Then I will skip it in order to don't extend the meetings.
No, yeah, don't worry. Just click on full screen mode. On my PC, it is a full screen. That's a problem. Is it now full screen? No. So sorry, I will skip it and go back to the presentation in order to avoid such a long discussion. Okay, and within this video, it was visible that all procedures into the leg trial were done by a total laparoscopic or total robotic procedure. And this was always associated with the use of a manipulator and the opening of the vaginal cuff at the end of the procedure to the circulating CO2. That means it was a planned tumor cell contamination if there was residual tumor, and sometimes it was not resection margins, and this was even not done by our pioneers, by Friedrich Schrader, who closed the vaginal cuff vaginally, and also by Ernst Wertheim, who closed the vagina with his own designed clamp and cut it the vagina below the clamp. And we tried always to avoid it because we always create a vaginal cuff vaginally before we go to the laparoscopic part. And thus we think we could always avoid this manipulation in contrast to the leg trial, which is shown in the graph, where you opened up to the end the ring of the manipulator and the circulating CO2 is open to the tumor. And by analyzing our data of nearly the same number of patients, but it is a monocentric retrospective study, we could show after an 8-year mean follow-up period that we would have reached the same results than in the LUC trial, and then non the 10% inferiority. I don't want to tell you the details of our study. I think the problems of the leg trial, and each study I think has some problems. Of course, it is the only prospective randomized trials, but there was no on-site visit from each of the
principal investigators to check the surgery quality. There were only 2 videos sent to the MD Anderson Center and were checked. Nobody else has seen any of these videos. And we also do not have the information how many centers have violated the recurrence rate out of the 33 participating centers. And I know it from personal discussions with Pedro, there were only 2 or 3 or 4 of these centers. He didn't tell me the exact number, but these centers had such an unbelievable high recurrence rate that they have, according to the patients they put into the study, have really broken the statistical assumption. Meanwhile, we do have, after the first shock of that we all got, we have other studies. You see, and just published only the newest one, the most recent one, systematic review showing that there was no significant difference for the overall survival. Of course, the group by Pedro Ramirez shows a difference in that minimal invasive is inferior to the abdominal approach. The Italian experience, also no significant difference in the death rate. The European studies, the so-called SUCOR study, shows a lower outcome of the patient undergoing minimal invasive surgery, but only in these patients who had a manipulator and a visible tumor. So this seems to be a very important factor. The Danish robotics study also is without any difference, significant difference. And again, I think there are arguments, pros and cons for the laparoscopic approach. I think it was a shock for all of us. So for us, it was again the first thing to analyze your own data, and probably every center should do this in order to provide a patient in the future the exact outcome of both procedures, not only to say abdominal is better. They have to provide the data of the own center, because I think it's all the question of centralization, how many patients you treat by one of the approaches. And if you see that 75% of the radical hysterectomy are treated in US in hospital with less than 5 cases per year done by different surgeons, it means it can be 1 or 2 surgeries per year, and then you cannot gain any skills in this procedure. We have to wait for the new trials, and I think the new trials are already ongoing. You see there are more than 3,000 or 4,000 people in randomized trial for all stages. 3 of these trials are in Chinese ongoing. There's a REC trial for robotic surgery and another Chinese study, although with the same inclusion criteria than the LEC trial. And I hope that we get the results within a 4 or 5 year period. And that's why, in my opinion, the combined laparoscopic marginal surgery with a strict closure of the vaginal cuff should not be forbidden if we or you follow the basic oncologic rules. We have to have 4 to 6 years of uncertainties until we get the results of the newer studies. The same is, I think, not every gynecologic oncologist must perform a radical hysterectomy, because this increases the surgical quality. And again, wait for the randomized trial. I think for small tumors, even removed by a cone, and then without residual tumor, the laparoscopic approach is still a very valid procedure. And as you can see, we are still good friends, Pedro Ramirez and I, despite our controversies in this field. Thank you so much for the time.
Thank you very much. I mean, it was an excellent presentation. So to conclude, you would consider definitely laparoscopy for tumors less than 2 centimeters, as I understood?
Definitely, yes.
And between 2 and 4?
We inform all the patients about both trials. I give them the papers of both of the LEC trial and our data. And then, of course, it's not real. I think it's not really fair, but the patient has to decide if she wants to go the abdominal route or the combined vaginal laparoscopic. And in our experience, 90% are choosing the laparoscopic vaginal approach for these small tumors.
Okay. So we have two questions from the audience. In developed countries, what do you suggest for minimally invasive surgery, robot or laparoscopy?
Depends on your preference and availability.
So no difference between robot and laparoscopy.
I think there's no difference as long as you, again, as you close the vagina and don't open the vagina with any residual tumor to the circulating CO2. That's why you can do it at the beginning of the surgery, or you can do it in between. If you have, for example, done the laparoscopic removal of lymph nodes and you have proven that there's no lymph node metastasis, depends on you. But in these small volume diseases, I would still prefer the laparoscopic approach. And I cannot follow all the arguments I've heard and discussed with Pedro and others. And one of the colleagues from the SGO told me he's able to do a wartime procedure in all patients with a 10-centimeter fun steel incision. And I cannot believe this, because if you have a more obese patient, you cannot do a radical via a 10-centimeter incision. This is, in my opinion, impossible.
Okay. And we're also having the study coming from Karolinska for the robot, so you have to write about that. So there's another question. Well, actually, this must go to the president of ESGO, to Philip. What is the position of ESGO and Gemelli? I'm afraid it's another question for Dr. Kohler, but I don't know if Philip, you want to comment on that?
Yeah. The ESGO follow the trials, meaning that we need to have new data, new trials to have the definitive results of that. More privately, in my institution, we don't change our practice, because finally you saw that in patients with small tumor size, with stage 1B1, the difference in terms of survival are really thin between both approaches. So we continue to the laparoscopic approach with the same protective maneuver that we use as suggested by Christian. And for the patient with stage 1B2, between 2 and 4, as you heard previously with Remy, we use an initial brachy in this patient. So we need initial brachy and do thereafter with a radical hysterectomy by laparoscopic approach, because a majority of these patients had a full sterilization of the cervix after the initial brachy.
But still, the ESGO is not supporting at the time being, as ESGO is not supporting at the time being the laparoscopic or robotic approach.
Okay. We say that we need to follow the new trials and what is becoming the new trials open, such as been said by Christian.
Dimitrios,
that's pretty clear.
Just to say what we do in our institution, we follow the same rules. We do laparoscopy with all the protective maneuvers till 2 centimeters, but we are participating to the FRAC trial now. So every patient is randomized to open surgery or robotic surgery.
Okay.
Very good.
All right.
But we still use, in some cases, minimal invasive surgery after neoadjuvant chemotherapy, because we have now a trial on neoadjuvant chemotherapy together with immunotherapy in cervical cancer. In such cases,
that's another trial.
Yeah, yes.
Okay. Great.
Question.
Yeah.
I have a question. Just to both Christian and of course Giovanni, how can you justify to apply a surgical procedure via laparoscopy only for small tumors and excluding larger tumors? Is it because it is? We all know that for small tumors the percentage of relapse is very low. How can you test and emphasize the need to apply that approach only for low-risk tumors and not for high-risk tumors? Is it that justifiable? Just a philosophical question. Because in order to apply a procedure, in order to say that the procedure is safe, we could apply it to all tumors, to all surgically managed tumors.
Dear Dr. Odolakis, I really agree with you. Again, we have analyzed our data from more than 25 years, and this were the same inclusion criteria than the LAC trial, tumors up to 4 centimeters according to the old FIGO classification. And within this trial, retrospective trial, we didn't find any difference to the LAC trial. Thus, okay, we offer it also to patients with larger tumors. But if this patient, now we have to do it for legal reasons. If the patient says, okay, I have some fears and rather want to be with an open surgery, be operated by an open surgery, okay, then we have to do it. As long as we don't do it within a new trial. I hope the German group starts a new trial, but I'm not sure if they succeed with this. But again, now we offer both procedures. Our data suggests that we can safely perform it also by this combined approach, but the final decision is up to the patient at the moment.
Christian, maybe I want to inform everybody, all scientist members. From the Prevention Committee of ESGO, we have now prepared a new paper, how to report conization material, the depth, the horizon, or the volume. And we are now European Federation of Colposcopy and European Society of Pathology, ESP, also joins ESGO in this paper. I believe there is no standard in the definition of the leap or conization specimens, the length, the horizon. Very recently, I had a patient, the conization shows adenocarcinoma, and after the conization, the margins were still positive. They report the tumor size 13 millimeter, but it was continuing in the cervical canal. And I did an MRI showing 18 millimeter more in the canal tumor. And of course, we did an open surgery because it was larger than 2 centimeters. And at the end, the final pathology, no residual tumor. So I do suggest, how do you assess currently in your center the tumor size, just with the conization, especially when the surgical margin is positive?
Important question. Coming back to the imaging, I completely agree with you. It's sometimes difficult. Again, our data comprise also stage 1B1 up to 4 centimeters because we did it according to the old FIGO classification. And I think according to the previous speakers, the MRI is excellent to show in spread or in rupture of the cervical stromal ring. So you can probably with a very high sensitivity exclude a tumor which is beyond the cervical margin. And for the others, you can relatively good see if the tumor is more than 4 or 5 or 6 centimeters. And all the other tumors are, I think you can do this procedure with same oncologic safety as we have shown in our study. But so that, of course, the higher the tumor, the larger the tumor is, there is an increased risk for an adjuvant therapy, as also shown in the LAC trial.
Mm-hmm. So
20 more than 20% adjuvant therapies.
So just to make it understandable to the members of Centis, you suggest to make MRI and to have the tumor size by MRI before the conization.
It depends on, normally you get the diagnosis by a biopsy or by a cone. Depends on the cervical, on the tumor size and on the stage. So you have to consider both. But we do in all patients preoperatively an MRI to estimate is there a residual tumor, and then you have to add it to the cone. Or is there no residual tumor, and if it only a biopsy was done, okay, you have it's a definitive measurement of the tumor size. And according to this, and in consensus with the patient, then we are choosing the best way for the surgical approach.
In Murat, we are a little bit behind in the schedule. We have to move on. I want to ask the next question.
The next question comes to Turkey. Professor Faruk Kase, who is the president of Minimal Invasive Robotic Surgery Society of Turkey. The question is very hard. What do you think about set list criteria? Is it very old? Why we don't update these set list criteria?
Thank you very much, Murat. This is a very hard and very debatable question. And I want to share my presentation first of all. And can you see my presentation?
Yes, very good.
Yeah. Adjuvant treatment remains a controversial issue for intermediate risk cervical carcinoma. And these are the eligibility criteria of GOG92 set list criteria. You all know the details of these criteria. And the GOG92 started at 1988, but in 1993, 5 years later, the sample size goal is increased because of the lower than expected recurrence rate. Revised sample size goal was only 260 patients. And these are the results, recurrence by treatment regime. As you see, the radiation therapy arm has 13% local recurrence, and no further treatment arm has 19% local recurrence. This is the recurrence-free interval graphics, and severe or life-threatening adverse effects of radiation is very important. 2 patients had died because of the severe or life-threatening adverse effects at the radiation therapy arm. And in 2006, they presented the progression-free survival and overall survival of these cases. And when we compare the radiotherapy versus no further treatment arm, as you see, hazard ratio is 0.58, but when we look the overall survival, there's no difference between the overall survivals, these 2 arms. There's no statistical difference, these 2 arms. This is the criticism about this GOG92, not well powered for survival, as you see. Surgical arm of the management was not standardized. Tumor size assessed by only palpation, extremely poor local control in surgical arm. And after this GOG92, in 2018, Sibila published Prague, New York, and Melbourne data. As you see here, there's no difference between surgery-only group and control group. As you know, the control group is the radiotherapy arm. And at the conclusion of this data, an excellent oncological outcome, especially local control, can be achieved by both radical surgery or combined treatment in stage 1B lymph node negative cervical cancer patients with negative prognostic factors. And the substantially better outcome than in the GOG92 trial can be attributed to more accurate preoperative and pathological staging and improvement in surgical techniques. And when we compare these 2 trials, as you see here, the pelvic control in GOG92, as I mentioned, to 13%, in current study, 0%. This is very important difference between these 2 publications. And when we look at the guidelines, this is the ESGO, ESTRO, and ESP guidelines. As you see, adjuvant treatment for lymph node metastasis negative, parametrial involved negative, and surgical measures negative cases. We have 2 options. When in these situations, in the adequate type of radical hysterectomy has been performed, observation is an alternative option, especially in teams experienced in this approach. And in NCCN guideline in 2021, we see observation is another option, and you see these are the set list criteria. And we published our data in 2010. We published almost 200 patients, FIGO stage 1B cervical cancer. Only age and pelvic lymph node involvement were independent prognostic factors for our cases. And this is another publication about adjuvant radiotherapy for intermediate risk cases. And as you see, exactly the same difference between radiotherapy and control arm, but in conclusion, survival benefit from adjuvant radiotherapy differed according to surgical approach. This is the important sentence. And this is another publications in 2000 recently published data. We see recurrence-free survival and disease-specific survival, no adjuvant treatment arm, radiotherapy alone, and concurrent chemotherapy. There's no difference, as you see. And radical hysterectomy alone, without adjuvant treatment, may achieve a favorable survival for patients with intermediate risk cervical cancer is defined by set risk criteria. Criteria for adjuvant treatment in patients without high risk factors need to be further evaluated. And this is the National Cancer Database. There was no difference in overall survival between patients who did and did not receive adjuvant therapy. 4-year overall survival rate exactly the same. And if we see any recurrence, especially isolated local regional recurrence, the mortality from isolated local regional recurrence in patients with intermediate risk factors for cervical cancer who underwent only radical hysterectomy type C2 was only 2.5%. And this is the another prospective randomized trial on the role of radical surgery and adjuvant therapy in management of intermediate high-risk cervical cancer patients, Cervantes study. We have to see we have to wait the results of this study. Why a new trial? The role of traditional prognostic markers has been challenged. Evidence for the benefit from adjuvant radiotherapy comes from an old trial. Recent retrospective data showed that excellent local control, the significance of individual markers should be re-evaluated, including NO1's targeted film distance and functional MR. Thank you for your attention.
Thank you, Professor Faruk. It was wonderful slides. We are, you know, in all hard talks, my friends, we are always lacking time because it's hard talk. It's open to discussions, you know, and it's big questions, and we have very important European experts. But it was a very nice summary. Of course, all will be downloaded in our webpage. Professor Faruk, we have really hard questions to you coming from the participants, but I believe everybody, all panelists can comment on that, can comment on this question. One of them is that I have lost my trust on service criteria. So you did something different. So how do you decide radiotherapy in Turkey if you don't use service criteria?
We use only 3 poor prognostic factors: lymph node metastasis, surgical margin positivity, and as you see, as I mentioned, we don't give radiotherapy according to set this criteria in our clinic.
From our clinic, it's the same, but it's always a big topic. Usually we have multidisciplinary tumor boards, and it is sometimes the surgeons win, sometimes the radiation oncology wins. So it's a win-win situation. It depends. It depends.
It's very normal.
Yes.
You have 2 options. You can follow up, or you can add additional radiotherapy in tumor boards. As you said, we discussed all the cases with radiotherapists.
And there is an interest on the members to make a survey, because they say that in many cases they do radical surgery in the Central region. I know in Belarus and in Ukraine, they are doing lots of radical surgeries. We will be happy if you may lead such a trial in the Central region. Last question: can we apply set list criteria safely to minimally invasively treated patients. So how can we reassure ourselves for our radicality? How can I assess myself if I am doing sufficient radicality or not?
Professor Kuhler mentioned this issue very well. The surging factor is very important. The standardized type C2 or type T1 hysterectomy is very important. We discussed the lag trials results because of the operator factors. It is very important. We cannot standardize it because of that. If you want, you can apply this criteria after minimal invasive surgery, or you can say this is the same result for the open surgery. Because of that, we cannot want to use adjuvant radiotherapy.
Okay, so keynote message is that even if you do minimal invasively, you can reassure yourself that if the parametrium is negative, then it is negative. I mean, it does not mean that you are doing less radical surgery and you miss a major prognostic factor in cell list. Okay, I think there are, of course, coming questions, but let's move to Christina for the next questions.
So thank you, Murat. So we go to Dina. Dear Dina, imagine you are in a country with no availability of radiotherapy, no infrastructure for it, and a patient comes to you with a bleeding large cervical tumor. What do you do?
First of all, in Georgia, we have three variant radiotherapy, so we not have a lack of assessment equipment of radiotherapy. But some of parts of developing countries such as Asia and South America, where access to radiotherapy facilities is limited, neoadjuvant chemotherapy before surgery is appropriate option for women with locally advanced diseases. But really, adjuvant chemotherapy in such it's still questionable in terms of its effectiveness, because there was a very big study which performed in its infrastructure research trial, and it was involved about 30 women in this stage 1B2, 2A, 2B, common cervical cancer, were abdominally assigned to either 3 cycles to neoadjuvant chemotherapy, paclitaxel and carboplatin on 1 every 3 weeks, followed by radical hysterectomy, or to standard chemoradiation. Compared with standard chemoradiation, those receiving neoadjuvant chemotherapy followed by surgery experienced 4-5 years DFC. There was a 69.3 versus 76.3 respectively. Hazard ratio was 1.3. However, 5-year overall survival was similar between the two groups, 75 versus 74% respectively. And the delayed toxicities at 2 years or later after treatment completion is worse in the group treated with chemoradiation compared with neoadjuvant chemotherapy, and it included rectal, bladder, and vaginal complications. And in conclusion, I have to say that neoadjuvant chemotherapy prior to definitive hysterectomy does not offer an overall survival advantage related to primary chemoradiation, and it has been associated with low disease-free survival. And therefore, in a geographic area where chemoradiation can be performed, we prefer to administer chemoradiation rather than neoadjuvant chemotherapy for locally advanced cervical cancer.
Excellent, thank you. That was very documented, very fundamental. So would you, just a question out of curiosity, let's assume you are in a country with radiotherapy, Yes, would you prefer, would you favor neoadjuvant chemotherapy, or what are your views on neoadjuvant chemotherapy?
We prefer in local advanced, unfortunately in Georgia, in 2019, we have 320 cases of cervical. We are registered in Georgia, and which 5.6 of the all registered new cases in women, and 5-year survival rate for cervical cancer diagnosis In 2019, we have, in 2015, we have 5-16%. So it's very hardly. And in local advanced carcinoma, we prefer chemoradiation therapy, not neoadjuvant care.
Also, as per the data, I mean, there have been prospective randomized trials that have actually proven that. Excellent. Thank you, Dina. Anything from the panelists? Otherwise, I think for the sake of time, let's proceed. Dear Philippe, very important question that also is very close to my heart. I remember when I started training many years ago, we used to give chemorads, and then at the end of the chemorads, we used to do like an adjuvant hysterectomy. Yeah? I mean, always. That's how we started. Now, of course, it's hardly ever being done. What are your views on that? When would you do a hysterectomy as an adjuvant, like as a post-chemorads?
You are muted, Philip.
I just want to show my screen, and I prepare some slide about it, but I don't see them. I don't know why. So just briefly to summarize, I don't see my slide, but it's not a problem. Previously, we have randomized trial in 1999 who show that 45% of patients with initial external radiation therapy plus brachy as a residual tumor. It was the beginning of the story of the completion hysterectomy in the context of patients with chemoradiation. And we have also very strong data. For example, we published our data in 2010 of the high morbidity of the completion hysterectomy, with up to 24% of severe morbidity related to GI tract morbidities or bowel morbidities. And finally, we have a very strong evolution of the brachytherapy and external beam radiation therapy process. And now we have no 3 randomized trials that have been done trying to answer to this question. The first one is a KEYS trial that have been published in 2022, in 2002, if I may, comparing hysterectomy or not after external radiation therapy. It was at the time of external radiation therapy, not at the time of chemo rates, and this trial was negative. It was an interesting trial because for North American teams, it was the end of completion hysterectomy in the context of patient with external radiation therapy plus brachy. We have our trial. We conduced a trial in France comparing hysterectomy or not in patient with chemo rates and brachy, but unfortunately, it's not a surprise from your side. Many of my colleagues in France were at the time convinced that we need to continue with the hysterectomy. So the trial was stopped by a lack of inclusion, but it was a negative trial. And more recently, we have a very interesting trial from Cetina in Mexico, which was a randomized trial comparing chemo rates plus brachytherapy in one arm or hysterectomy in the other arm. And this trial demonstrates that the survival is the same, but the morbidity is quite higher in patients with hysterectomy. So finally, I think that we have different teams who are working on this subject very efficiently. If I may, Giovanni is continuing publishing on this combination with a very strong data supporting that we can have a place for hysterectomy in patients with external radiation therapy plus chemo, but without the brachy. But in France, nearly all all my colleagues stopped to use the hysterectomy. So clearly, my position is to say that there is no indication of hysterectomy in this context, except 3 different situations. The first one is no accessibility to brachytherapy. If you are in a country where you have only external radiation therapy plus concurrent chemo, do not increase the dose of external because the biology is not the same. Consider the place of hysterectomy. If you are in the situation with residual tumor after brachytherapy, the combination of hysterectomy could be considered, but we have not the proof of increasing the survival in this context. And the last part of the potential indication is the trials. perhaps you are in country where you are continuing to evaluate the place of hysterectomy in this context. You can proceed in the very strict inclusion criteria of a trial. But from my side, it's really very few indication of hysterectomy after chemorrhages and brain.
Yeah. Fully agree. And the morbidity is massive now. If you start operating all of them, then the morbidity, bladder retention problems, bladder emptying problems, fistulas. I mean, it's a disaster actually. I mean, I remember I used to operate this patient and they couldn't urinate. Good, thank you. I think we need to speed up a bit. So I give back thank you very much. I give back the word to Demetrios and Murat.
Yeah.
Okay, so the next question is going to Vladislav Shupkin, and it's a very hard question. Vladislav, it's about exenteration in cervical cancer. What is your views about that? And if there's any role of palliative exenteration?
So, dear colleagues, the case is very difficult. And first, it was in year 1948. The palliative procedure of pelvic exenteration was proposed by surgeon, and the aim was to reach R0 resection. And after that, it was extrapolated also to oncogynecologists. But actually, it's quite different to perform selection in order to find patients in whom it's very possible to perform R0 resection in advanced cases. And in many clinics, it was found out that there are a lot of so-called side effects. I mean, fistulas, inconsistency, and so on. And patients need to stay on bed for a long time at extra costs. Due to our experience, actually, we also refused this procedure, and we'd like to perform beta radical radiochemotherapy, maybe with extra adjuvant chemotherapy, and we have better results in such patients. Of course, there is a place to try to perform pelvic exenteration in patients with central local relapse disease. But it's also the same situation when patients need to stay on bed for a prolonged time, because the healing of such wound after a radical course of radiation therapy decreases this healing process. We can see even side effects during the full course of radiation therapy, changes on mucosa in vagina. So it's quite understandable because of sclerosis of vessels, it's quite difficult to perform healing. So maybe in just some cases for just selected patients, that's all. But in literature, there are some publications of different schools that they were performed also minimal invasive surgery for such purpose and even robotic surgery. But from one hand, it's good technically, and they announce that patients have left the clinic in 2 weeks. But from another case, not every clinic have such a good support.
Okay, thank you very much. I mean, it's been exenterations have been on for a long time, but still the thing is that nowadays we still have an overall survival of about 50 to 55%. And it's this peculiar because this procedure has been on for a long time. The post-operative care is better now. The surgery that we're doing is better. The instruments that we use are better, but still the overall survival remains the same. But thank you very much, Vladislav. And of course, it's very interesting what you said about laparoscopic assessment. I believe Dr. Kohler has published on that, and he has published that the most peculiar and difficult sites, the parametrium, and it's difficult to assess even in open surgery. I believe it's much more difficult in laparoscopic surgery. Do you want to comment on that, Dr. Kohler? You're muted. You're muted, we cannot hear.
Sorry, I apologize. I completely agree with you. It's for a couple of patients, for the very selected cases, exenteration is a very valid alternative to in primary chemoradiation. And I agree with you, the most difficult problem is to select the patients, if it's appropriate or not, if you can achieve sound margins or not. There is I think it was the largest group done in Germany for more 100x iteration by Professor Egger. He also could demonstrate that in cases where he could not reach sound margins, this group has a survival of 10 to 12%. But it is 1 out of 10 which will survive, and you do nine procedures without any succeed, and these are major procedures. So it's very difficult to decide. I agree with you.
Thank you very much, and thank you very much, Vladislav, for the excellent answer that we have. So the microphone is now to you, Murat, for the next question.
Yeah, thank you so much, Vlad. It was a hard question, really, exenteration. But I want to add a comment. As Dimitri said, the number of exenteration is increasing day by day. So we are almost finishing our second hour, and I will give you some real numbers now. But let's now ask a hard question to Köhler again. So what is your treatment decision when you have a sentinel lymph node positivity? Do you have any difference in isolated tumor cell positivity, microscopic positivity, or gross positivity? So you are a leading person in Europe in this respect, and we will be very happy to listen your experiences and advices on that.
Thank you again for the invitation. I'd try to give some critical remarks to the sentinel procedure altogether. Can you please see again my slides?
Yes, very good.
It's without a video, so it should run smoothly. Again, sentinel is a promising technique for patients with early cervical cancer, but in the lower picture, you can see exactly the most difficult thing. You have a blue sentinel lymph node without tumor, and side by side, there's a tumor-involved lymph node without color. And if you miss him, okay, this is a gross one. This would be the nightmare for false negative. We have a high detection rate of the sentinel procedure, especially if you find a bilateral detection and can reach this. And the best detection rate was found in early cervical cancer if this is less than 2 centimeter or 1B1 to less than 4 centimeter is under discussion. It is a good result that the sentinel node does not impair the oncologic outcome according to the Sentinel-2 study. It was just published, the results, and there was quite no difference between both groups. But again, I think we do have had in the past more expectation to the sentinel concept. We do have enforced an easier intraoperative treatment decision for the sentinel, and only want to examine the sentinels. We want to lower the rate of the lymphodemas. And again, the question you just included in your general question, what do we do with the small volume metastasis, and what are the clinical implications? Let me come to this aspect. According to the first results of the Sentix trial, the sentinel frozen, as you can see in the just published by David Cibola, was accurate only in more than 55% of the cases. What about the others? That's why when we got these results, because we actively participated in this trial, I was really surprised, and immediately we had to start to analyze our own histologic results in our hospital, because what is the consequence of this? Should we always do a two-step procedure? Of course, this is a better for an exact histology with ultrastaging and immune histochemistry, but sometimes it can be a surgical challenge. If you have opened all the spaces for looking for a sentinel in all different pathways, and later on you have to perform any radical procedure a couple of days later after getting the results, it can be very difficult. The second question is lowest rate of lymphedema. And you see both groups, the Czech group, the international Czech group, and the French group. You see in the published data also from the Centix trial that the rate of mild and moderate lymphedema was also 26%. This was a fact we tried to avoid using the sentinel concept, and also in the just published by Patrice Matevé from the Sentinel-2 study. However, there was no significant difference in the proportion of patients with significant lymphedema between both groups, the complete and only the sentinel group. This is really not our aim of the sentinel procedure. And the last and most important question, what do we do with the small volume metastasis? Do we detect more and do we get a better oncologic outcome? Again, the just published oncologic outcome from the randomized Sentinel-2 study did not show any significant difference. And the question of micrometastasis and isolated tumor cells, is there any clinical relevance for all of us? There are publications that say no, there's definitely no difference in the survival rate of both. And there are the Czech group definitely found in more than 600 patients, there was a difference, but only for the micrometastasis. What should we do in the future? I think this is a totally unanswered question. I think the sentinel concept also has its very critical points, and it's not only encouraging procedure. Potentially, we can combine the sentinel histologic examination with the OSNA test or the commercially available mRNA test interoperatively, because they can work very quick, and then we can hopefully overcome these problems of the low rate of frozen section accuracy of the sentinel in order to make an better interoperative decision. We definitely need, and I think this was a huge task for this group, better studies for the treatment and the clinical prognosis of patients with micrometastasis as well as isolated tumor cells, because it's totally unclear what we do. A few groups treat it as a metastasis with chemoradiation, others don't do anything. And finally, the good news are at the end, we have 2 ongoing trials, or 2 trials that will provide a lot of information in the next future. This is the Centix trial, and later on the Sentinel trial with nearly 900 patients, and hopefully we get answers to this question. But I cannot give you a definitive answer up to now. Thank you so much for your kind invitation again and the attention.
Christoph, thank you so much. Again, a very wonderful keynote messages. Actually, it's again a hot topic. Sentinel lymph node applications is increasing day by day. We have actually several questions to you, and maybe our panelists can comment. One of them is that ESGO guidelines suggest sentinel lymph nodes may be applied. Why ESGO is not saying should be applied? Is the ESGO guideline committee is not reassured with the available data? What do you think? Should the guidelines say should be applied or may be applied?
I think up to now, according to the problems I've just demonstrated to you, I think this is the right statement. And before we don't have the final result of the Centix and this, as well as the Sentinel 3 trial, we should keep this statement as it is at the moment.
Yeah. Okay. What is the role in FIGO staging if you have an isolated tumor cells? And do you finish the surgery if you have a intraoperative microscopic frozen section lymph node positivity?
We really strictly abandon if you get the frozen result of any positive lymph node. So independent if it's a micrometastasis or an macrometastasis, so we still move forward to send these patients to primary chemoradiation. But again, it's questionable for patients with micrometastasis, and the result of isolated tumor cells you will never get during the frozen section. That's a problem.
Very clear, very smart answers, Christian, as usual for you. Any comment from our panelists?
Yes, Murat. Just a comment. I think that OSNA could be really useful in such situations because you can have, because it's a very reliable method, and you can get an intraoperative evaluation of the lymph nodes status, and so I think that this should be developed more and more, because it's what I think is that the two-step the frozen section analysis is not reliable in cervical cancer, so we have to identify molecular methods to have an intraoperative evaluation.
You are right. In my center, our pathologists do not accept still the frozen for sentinel lymph node procedure. They say that they are not so well experienced. They can miss some tumors, and they refer us to make more molecular-based frozen sections to help them, to guide them. Christian, do you have any experience with these DNA analysis, so-called OSNA, nuclear amplification method?
No, we don't. I don't have the experience with the OSNA, but we have done an similar testing with an HPV MNR test, because if you have an active tumor cell, that must be an mRNA, because this is the only active form which has a transcription inside. The DNA can be also caused by death cells, and it's not a vital tumor. So we have done this trial with more than 200 patients, but we are just working on the analysis. If we could find the same results or even better results than with frozen section or ultra staging, and hopefully overcome the barriers of this problem with the isolated tumor cells and micrometastasis. But I completely agree with Professor Scambia. This is an ongoing problem. The question from me to you is, are you happy with the decision of your pathologist not to do a frozen section? I mean, always a two-step procedure can be a challenge on the second time. It can be sometimes very easy, but in other case, you can have a lot of lymphatic fluid, lymphocysts in this area where we want to do the surgery. And again, I'm not happy about this. I wouldn't be happy about the decision.
I mean, we are still discussing in our tumor boards. I did several times frozen section, but our pathologists really do not agree with me.
Of course not. Of course not. Mine neither.
The main problem here,
sections.
Christina, the main problem here in Turkey, there is an increasing malpractice issues. The numbers in gynae-oncology and obstetrics is increasing. We are becoming a small USA. Maybe Professor Faruk can also comment the situation in Turkey, but every people now is afraid of a malpractice issue. The lawyers in Turkey are nowadays like New York lawyers, following all the surgeries. So we were a social European country, but becoming United States, malpractice is increasing. So of course, it also affects the pathologists, and they want to have a more structured infrastructure, the algorithms, even approached by Social Security Institute and Ministry of Health, to make the procedure routinely done. I believe it's a problem in many developing countries, but I cannot say to him, no, you are, I mean, we cannot decide among each other. At the end, there is a judge and the people are afraid of that. But it needs some time. It needs some time for people, for patients, for doctors. Any comment on that from different countries? Here, Faruk Köse is leading the Sentinel lymph node in Turkey with Fırat Ortaç. Did you have any malpractice issue, Professor Faruk Köse? And I mean, this is a hot debate in Turkish meetings too.
Endometrial carcinoma.
This is a problem in endometrial carcinoma, you say, especially.
Patients with endometrial carcinoma, because of that, there is no problem about that approach. But in the patients with cervical carcinoma, it can be a problem for malpractice just now in Turkey.
Yes, yes. This is not related to the societies, to ESGO. This is how our lawyers in Turkey make money nowadays. And we are not in a good friendship with them. That's how they earn money. And I believe it's a problem in many other countries. But I want to inform you that we have still questions, but we have to move. But currently, we are in the 2 hours and 10 minutes additionally. Still, we have 250 live participants listening us. It's a very huge, the people have lots of questions, but we have to move. And the microphone is, if you have no more comment, is now with Christina for the next question.
Which is the question number?
Number 13.
13.
Yeah.
Which goes to Giovanni.
Okay.
Hi, Giovanni. So that's now a very nice question for you, who are an excellent surgeon and a radical surgeon. So what are your views in regards to less radical surgery? So we have increasingly new data. We don't have the results of the SHAPE trial yet, but I think the SHAPE trial will be a negative study, yeah. What are your views on the oncologic safety of less radical surgeries for smaller cancers, of course?
Okay, so thank you, Christina. It's really an interesting question, and I can try to share my screen. Do you see it?
Yes, yes, yes.
Okay. Okay. So I think that we know that the increased radicality during radical hysterectomy is associated with intraoperative and postoperative complications. So what we can say is that the rationale for less radical surgery is based on the assumption that in low risk cervical cancer, parametrial involvement is extremely rare, less than 1%. So we can think that less radical or non-radical surgery appears to be appropriate for many women with early stage disease. However, we need robust studies to confirm this assumption. And this is the SHAPE trial you mentioned before, that is a randomized controlled trial, very clear, aiming to assess the risk of relapse in performing simple hysterectomy in low-risk cervical cancer. But the results will be available in 2 years. So what is interesting in my vision with this trial is that the minimally invasive approach was preferred in the entire trial, and it will be interesting to analyze the unanticipated consequences of the LAC trial in patients enrolled in this SHAPE trial. Another trial is the CONSERVE trial, which is a prospective trial of conservative surgery for low-risk early-stage cervical cancer. This is a single-arm prospective trial analyzing the impact of non-radical surgery, conization of simple hysterectomy on survival. As you can see, patients were included if they had a cone biopsy with negative margins, and they received conization or simple hysterectomy according to their desired fertility preservation. Preliminary results were shown 2 years ago at the EGCS conference and showed that with a median follow-up of 25 months, recurrent disease has been diagnosed only in 3 patients out of 100, so 3% of recurrences. So the conclusion could be that the CONCERT trial suggests that less radical surgery is safe in women with low-risk cervical cancer. However, we remember that the lymph nodal assessment is still recommended in these patients, and we need a long-term follow-up that will be now available and that will be published in a few months in order to get the final conclusions of this study. Finally, the GOG 278 trial is a multi-center prospective cohort trial similar to the previous trials, but the endpoints were only bladder bowel section dysfunction, lymphedema, and efficacies. So in conclusion, I think that we should probably in the future we will do less radical surgery, but this is based on different retrospective studies supporting low-risk parameter involvement in low-risk cervical cancer. We need to wait the ongoing prospective studies results, but I think that the future perspective may focus on less radical surgery thanks to new diagnostics and surgical technologies. Moreover, we did a lot of improvement in reducing radicality on lymph nodes, and this will contribute to further reduction of surgical morbidity. Thank you, Christina.
Thank you, Giovanni. As always, excellent. Thank you very much. I think we are all not in fear, but we all have that we will stop operating anymore. I mean, we can't train anymore in radical hysterectomies. We are losing the skills of a radical parametrectomy, the dissection on the pelvic side. Yeah. It's very interesting. Because I fully agree with you, in the future, it will be less and less the radicality in those operations.
Yes,
so when there is necessity to do it, we will not know how to do it.
Yeah. Yes, I think, Christina, that in the future we will have a clear divergent way, 2 clear divergent ways. As soon as more and more diagnostic improvements and biologic characterization of the tumor will allow us to reduce radicality. But in cases in which we have recurrent disease or we have chemo-resistant disease, we have to do more radical surgery. So it's really a very challenging situation, even from an educational point of view for our young surgeons, because they will do less radical surgeries, but when needed, they
won't be able how to do it.
Yes.
The same with the lymph nodes, yeah. We have stopped doing lymphadenectomies. We only do them when they're bulky nodes. So when they're bulky, it's impossible. It's difficult to go and train somebody.
Yeah.
So it's very tricky how to give this knowledge. Yeah. Thank you. If there are no further comments, then I think we should conclude. We should go to Dimitris, who has the last question to Professor Odorlakis. Dimitri?
Thank you, Christina. I was muted. So from less radical surgery, we're going to more radical surgery. So the next question goes to Alex Rodolakis, and it's about the MMTR surgeries. We know that this surgery has been on for a long time. It was invented by Professor Hockel, and I would like to hear your opinion about that.
Thank you very much. MMTR surgeries have been challenged the model of randomly diffuse local tumor spread for carcinoma of the surgery, and they have provided evidence that local propagation is determined by cancer fields, which is anatomically defined by the mature tissue derivatives of the morphogenetic fields. which is involved in the development of the mature tissue from which the cancer is derived and originated. The tumor is spread only in the cancer field of an individual tumor, and of course it's with the sequence of and the size of the associated cancer fields being fixed by morphogenesis, give rise to the concept of the ontogenetic staging and cancer field resection in oncology. That ontogenetic local staging for cervical cancer is feasible, and that the incorporation of that cancer field resection into various procedures like the total mesometrial resection, together with the therapeutic lymph node dissection up to renal veins without giving any adjuvant radiotherapy, that supposedly has the potential to improve treatment results compared with conventional principles of practice. The surgical procedures, the TMMR, the total mesometrial resection, comprises of the removal of the whole Müllerian compartment, and the extended MRI is the total mesometrial resection along with adjustment issues like bladder adhesion, mesenteric wall, and ureter. And of course, the therapeutic lymph node dissection comprises lymphadenectomy from first, second, and third line lymph node mapping up to renal veins. Out of 500 patients has been treated, and these patients are patients with disease with FIGO stages 1B1, 1B2, 2A1 and 2 and 2B without any evidence of bladder involvement and had been managed. And the results, the 5-year survival rates was up to 89%, with recurrence-free survival 83%, with acceptable related complication, operation-related complications. The oncological result of this prospective study that has been shown that which is based on cancer field surgery without any adjuvant radiotherapy, it compares, the results at least, compares favorably with the traditional surgery and adjuvant chemoradiotherapy on the basis of histopathological risk factors and, of course, with primary chemoradiotherapy. It is interesting that it is found different prognostic value about peri-aortic lymph node metastasis on the basis of whether second light basins in terms of common iliac lymph nodes contain metastasis or not. All patients without whose basing do not contain, in case we do have upper para-aortic lymph nodes metastasis without having any common iliac metastasis, have a local infiltration of the uterine corpus, and these patients did not seem to differ the prognosis from those patients with only pelvic lymph node metastasis. On the contrary, patients with peri-aortic lymph node metastasis in presence of common iliac has a worse prognosis. These results, of course, are only for coming from a single center institution. They has not been reproduced by other centers. And of course, the successful outcome of that study, only with a multi-center randomized trial that can compare this cancer field surgery as specified by procedures like TMMR or the extended MMR with the therapeutic lymph node dissection, and to compare with the conventional surgery plus chemoradiotherapy for carcinoma of the cervix stages up to 2B without infiltration the bladder.
Well, thank you very much. And no, this is a paradox because it seems like a very appealing technique, and it has been on for many years now, but it has been used only in very few centers, and mostly in Germany. I would say one center, definitely the center of Hockel, and maybe some other centers in Germany. And I would like to ask the rest of the panel also if they're using TMMR, and why do you believe it's not reproduced?
Christos, do you want to answer? Christos, what is your view? Do you do TMMR?
think Christoph has left.
Left us. Philip?
No.
Why not?
Why not? Because it's not a question of techniques. It's also a question of concept. Also, with a compartmental concept. To be very honest, I'm not 100% in full agreement with the theoretical view of the compartmental view of the spread of the tumor with the TMMR. The TMMR is based on this compartmental spread. And also when Ockel present the results, there are very strong results published in Lancet Oncology for several times by Ockel. We have also good results even in patients with positive nodes. So clearly, perhaps in the end of color, the results are good. I'm not sure that the way to spread an exclusive surgical management in patients with positive nodes is really safe. Except
Philip is against. And we have a comment here. I have visited Hockel Center to see TMMR in 1 month fellowship. I have only seen one case with 17 hours duration. 17 hours.
No, yeah, so Hockel is a very, very meticulous and particular surgeon. A very, very detailed surgeon.
He's excellent, and probably the reproducibility is visible in the hands of Ockel's, but probably less visible in the hands of other surgeons.
Exactly. And it's not really the time of surgery. I mean, I don't really like when people say I'm too fast, I'm too slow. You know, it's about the way of dissection, the care that you provide. It's not really the actual minutes of the operation. But yeah, the reproducibility is an issue.
Surgery is a long time for a surgery.
It's a very long time. I mean, you need 3 teams of residents and fellows.
Yeah,
and the next morning you cannot work on that. Everybody should be on holiday.
Perhaps it's a bit exaggerating, the 17.
I do
it was together with a break, together with a lunch break.
Any country who is making TMMR in the Southeast region. Professor Faruk Köse, I found one surgery that you don't do. Cannot you make TMMR?
Of course not.
Look, we are now recording. I will share it in Turkish society. Once again, I am asking, cannot you make a TMMR surgery?
We can perform TMMR surgery. We performed only 2 cases. As Philip mentioned, this is not only a surgical approach. We tried, but we can perform easily because we used CUSA, especially for the selective nerve sparing surgery. But as mentioned and in the questions, it's a very long time for only one type 2 surgery, hysterectomy.
Okay.
Very nice.
And you, Christina, do you perform this?
Yeah, Christina.
No.
You don't?
No, I don't. And I am somebody who was trained by Lichtenegger, who was trained by Burkhardt, where we used to do 2Bs, radical hysterectomies in 2B, so I don't.
But are there any centers in Germany performing it?
So in the Charité, I know we don't, at least we didn't till I left. Andreas Dubois, I don't think he does it, to be honest. I'm not aware of.
Okay, so it's only one center.
Still one
I'm not aware.
Okay.
I'm not aware.
Is David Sibula making the surgery? Did he has any publication? No, I think he's not.
I don't think so.
So it's only Hockel. Okay.
So I think that we should combine the next 2 questions. What are the problems in cervical cancer with Centist and how ESGO could be helpful to that? What do you think, Christina?
Yeah. Yeah,
well, definitely. Yeah, definitely. So we are now in communication with Murat and you with the whole team that we do some specific targeted efforts for the for the Central countries, definitely. And this is something that will come, especially in terms of even screening. You know, it's different. The accessibility to screening, to all the newest methods of molecular screening, etc. So we are definitely very interested in that, and that is something where the guidelines group will focus on in the next time.
Yeah. Now it's time to listen some voices from Scientist Geography. It's our pleasure. We have the ESGO president here. Please, let's talk honestly. What are the problems? And then what ESGO can do for you. Maybe we can start with Dilyara. Dilyara.
Yes, I'm here. We have several problems in Kazakhstan. First problems during 25 years, we saw the incidence of cervical cancer is increasing in our country, despite 12 years screening, and annually we detected 1,700 new cases, and mortality unfortunately stable and have high level. Because detection in third and fourth stage is 15% of new cases. All treatment in Kazakhstan and screening are free for patients by pap test, and one of the main problem, we need to change cytology test to HPV test, and we now in progress of HPV vaccination, but we are now in line of waiting it. And one huge problem is the lack of high-level specialists who provide surgical treatment. And all patients refers by regions to our institute for surgical treatment, of course, and for radiation therapy. It's one of the main problems. And we updated our clinical guidelines after results of LAC trial. And Kazior took a part in SUCR study with more than 200 Kazakhstan patients. It's our results was included in SUCR study with Chiva. It's one of the main problems. Thank you.
Thank you so much, Dilyara. I know what you are doing in HPV DNA screening, and I hope, wish, and support you with all my heart and brain to be successful. Kazakhstan is becoming the first country in Central Asia to convert to HPV. Maybe some voice from Georgia. Dina, what you can say in cervical cancer control in Georgia? What you can ask from ESGO?
Yes. First of all, I want to just only brief information that cancer screening programs have been operated in our country since 2018. Target population also screening for women age 25-60, and screening rates for the target population is very low, 10-12%. And also we provided HPV DNA PCR test, but it's very expensive in Georgia, unfortunately, and a lot of women do not allow it. And also we have a problem with just colposcopic. We have not a lot of training in all of region of Georgian colposcopists. And also we certainly note mapping the procedure is not available in all of region of Georgia. And we have these two problems, very big problems.
Well, Vlad, how is going on in Ukraine?
So actually the situation during the last 3-5 years is better than before if we are talking about screening process, because our gynecologists in place are more trained as before and prescribe widely tests, and we can reveal HPV infection. What about vaccination? There is no national program, and it's quite individual. If there are some individuals who want to be vaccinated, it's free. vaginal program is low. And due to earlier screening, we can have less advanced cases.
Thank you so much, Mulat. Professor Faruk, any voice from Turkey?
Yeah, of course.
Problems.
Thank you very much. As you know, we achieved a very nice population-based primary HPV screening in Turkey with Nejat Özgil and with you. You were the head of the National Cancer Institute. And after that, we achieved, as I mentioned, population-based screening. This is a very nice, and we are the pioneer of the primary HPV DNA screening testing. But we have a problem with the implementation of HPV vaccine to the national program. If we can solve this problem, implementation of the HPV vaccination, we can solve the problem, because when we look at the incidence and mortality rates of cervical cancer in Turkey, we have the lowest incidence and mortality rates in our region.
Thank you so much, dear Faruk Köse. So actually, we see that the very common problem and the wisdom is screening and vaccination. Of course, you are all specialists in gynecology. You somehow do your treatments, but you see that you are lacking in prevention. And of course, as the prevention committee chair, it should be first me who should promise you to do more and more and more. But believe me, we are a small team. The prevention committee is just established. We are growing day by day, and I promise myself, on behalf of ESGO and the prevention committee, we are together. Whatever you need, scientific products, lobbying, advocating, ministerial meetings, we are together with you and happy to support you with ESGO professional leadershipness like Mark Arbin, Mara Kurigu, me, Elmar, Yora, and we will produce more and more for you. And I want to give the last words to the, of course, ESGO President Philip. What's going on in ESGO? There are some comments, Philip. The people love ESGO a lot. And they want to see ESGO much frequently. Yeah, some comments from you.
You to give me the input from Kazakhstan, from Georgia, from Turkey, and from Ukraine. I just show you a couple of slides just to show you where we can continue to help you, just to show you what have been done during the last month with the ESGO. The ESGO is a family. You know this family. This is the current council. You can see a lot of faces that you know perfectly. Many of these faces are currently chairs of different committees that are in charge of different points that you raised during the last minutes. And I would like to thank also the past members from your regions, Dina, Elena Ulrich, Chagatai is there from Turkey. Murat was previously a member of the council. I saw the face of Dimitrios, of Alexandros, who were there few years ago. Here, it's the first point that we did is really to increase the spread of the knowledge of the guidelines in your regions and translating the guidelines, which is a very huge product. And now it's under the chairing of Christina. And so this committee is really crucial because it's really productive. You have the new guidelines of endometrial cancer is done and will be translated in the apps and translated in Russian language, but you have the previous endometrial cancer pocket guidelines, vulvar cancer, ovarian, cervical that exist now in pocket guidelines in Russian language. You have also a new section on the e-academy that have been created a few months ago under the help of Artem Stepanian, who is really helpful to help us to develop this new chapter with a Russian language and a Russian collection. And you can see here the different coverage and the different talks that you can see here in this new chapter of the Academy for your countries and the Russian language countries. And also you have a newsletter specifically dedicated to your regions in Central Asia and Eastern Europe speaking Russian. And this is really helpful to keep the link with your wish, with your expectations, and where we can improve the development and the quality of the treatment of cancer. And this is also a crucial step there with this map. And it's linked with all the points that you stress. I am a strong believer of the help of the EU Parliament to help these regions to improve the quality of the vaccination, the spread of the vaccination, and also the screening programs. And you can see here a well-known map atlas that have been done and developed with the help of Murat, and Murat is really helpful with the prevention sharing with this kind of aspects, and is in depth involved with the EU Parliament. We are developing a new, very strong links with the EU Parliament to try to improve the spread of the vaccination and the quality of the screening program in your regions. This is why the ESGO is improving this link, which is from my side the best way to spread and to improve in your regions. And also the way to improve that is also the education. The chair of the education is Anna Fagoti. The chair of the guideline is Christina. We have Murat as the chair of these prevention committees. We have other chairs with Luis Chiva, for example, with the chair of the accreditation and the certification. And you can see here the location of the different sites that are accredited centers for training of gyne-oncologists or your fellows in these regions. And you can see here the training centers in Belarus, in Russia, and for the fellows accreditations, but also for the certification about the specific topics of ovarian cancer surgery. Now, Christina is working with Luis to spread the new trains, if I may, about the treatment of cervical cancer that will be launched in 2022. So this is an important topics and very crucial for the ESGO. You will have an ovarian cancer surgery, which is open since 3 or 4 years, and you will have a new one with the cancer treatment, cervical cancer treatment management with the cervical cancer surgery, but also radiation therapy. So it's very important for us to have in your countries at least one of the centers that could be a certified centers or accredited centers for the fellowship accreditations. So clearly we can help you, but we need to have a sharing system, if I may, and just to have a mutual agreement of we can help you, and you can also help us to increase the quality of the management of the patient across Europe and in Eastern Europe and Central Asia countries. So don't forget the next Congress, which is really important for us, which is organized in Prague in 20 October. And also, forget also a way to help your youngest colleagues to be member of the to have access to the academy, have access on different scientific contents products. But we create new committees during the 2 last years, and a new one with the prevention committee with the hospital and committee to improve the quality in your regions, connecting with the scientists across Europe, and also with the EU Parliament to have, because the EU Parliament have the money to develop these projects. So we need to be very proactive with them to spread to your regions and to help you.
Wow. Wow, thank you so much, dear Philippe. I'm really so excited. You know, I know lots of ESGO activities, but concentrating on the Southeast region, it's really amazing what you are doing during your presidency. I should say.
Myself,
Yeah.
group of people. It's not a group; it's a family. Okay? We have a very branding because it's in the council. Sometimes we have disagreement, but it's always a family branding, and we are really happy to work together and to develop together. It's not only myself, but it's,
yeah, of course. But I, as a person working in the council like Christina now, I see your vision. I mean, the committees targeted on spatial topics, targeted on spatial geographies. I know what you are doing in the Middle East, in the Central East Asian region. These are so privileged for us. At the first time in our history, we had a chance to apply for ENGOT memberships even. These are, seeing some Russian products, as I see in the comments section, makes the people so happy. So today also, I mean, these are important because territorially, the people feel themselves in the middle of Asia and East Europe, and they want to be more and more active and supportive to ESGO. And whatever you do is really seems fantastic for everybody. And I just want to say that 2023 meeting will be in Istanbul, and Professor Faruk Köse hereby promises you to make a wonderful Sentis session and Mimago session. Right? Professor Faruk Köse, we are recording your words. What you are now in Acıbadem University in Istanbul, and what do you suggest? What you will do in 2023?
It will be a pleasure for us being a part of this kind of organizations. Thank you very much.
Okay, so we will come to Acıbadem, to your university. Of course, all Southeast countries, we will be so happy to host you, Ukraine, our Greek friends, Georgian friends. We will have wonderful parties. So please keep your agenda. The Istanbul meeting also in 2023 too, with special programs with ESGO presidents. Okay, we are almost done. It is 1 hour delay, third hour. Dilyara, as you are the hosting, I want to give the last words to you before saying goodbye to everybody. Thank you so much for all your support from Kazakhstan, and the microphone is with you.
Thank you for all speakers. Thank you for all our panelists, and it was very fruitful, long webinar, but it was very necessary for all our participants. I think Southeast will be involved in all ESGO. We was in ESGO, but we haven't, как сказать это, we haven't maybe time to do all the things with you together, and I think we will be in Prague, and we will see you offline, of course. Thank you very much, Philip, and all participants and all speakers. See you next time, and Southeast Hard Talk. And thank you, Murat, of course, for your...
Thank you, Dilyara, for the support. Christina,
thank you very
Dimitri,
much.
Thanks to all of our panelists. Thanks to Dimitri.
Thank you very much.
Thank you for your
Christina.
time. Brilliant as always. Thank you. And thank you to Murat and Dilyara. Thank you.
Bye.
See you. Bye-bye.
Bye.
See you.
Bye-bye.
Thank you.